Of my chief instructor and my colleagues, I extend a very warm welcome to all of you to this instruction course. Now, when we talk of biometry in pediatric cataracts, the word pediatrics throws a lot of challenges. The first challenge, as you heard my other speakers, we are introducing IOLs in smaller and smaller eyes, in smaller and smaller children. So with the increased technology, with improved surgical techniques, we are now moving towards IOL in infants and very small children. And all these formulas that we use are all studied in adult populations. They have never been studied in pediatrics. They have been designed for adult eyes. They were not designed for pediatric eyes. Because pediatric eyes have a shorter axial length. They have much steeper corneas than that of adults. They have shallower AC depth. And as you heard my previous speakers, there is a very rapid growth in the first few years of life. As a result, there is a rapid refractive change in the first few years of life. The target post-op refraction is not emmetropia in children. It is hyperopia. So all these IOL power calculations, formulas, are all targeted for emmetropias. And last, the biometry is done under general anesthesia, whereas most of our machines need some fixation to lock in the values. So when we do it under anesthesia, we really don't have any fixation. Plus, you have seen that a small error in axial length measurement, that is about 1 millimeter error, can lead to a 2.5 diopter change in IOL, and this is larger, about 3.7 in very small eyes. And a 1 diopter error in keratometry can lead to almost 1 diopter error in your IOL power. The current formulas are all based on adult anterior chamber depth, which comes from the manufacturer's A constant, and these are all calculated for adult eyes. And we know the anterior chamber depth in children is shallower than that of adults. The expected lens position and the axial displacement of IOL is more pronounced in children because of the stronger posterior capsule contraction and the vitreous pressure, which causes expected lens position to be a little anterior. And then there is the effect of primary posterior capsular excess, vitrectomy, and a more proliferation of the lens material in children. So all of this make the formulas which we need to use in children a little bit complex. The various formulas that we use are the second generation regression formulae like SRK2, the third generation formulas, the theoretical one, the Holiday 1, the theoretical formulae with some regression inputs, the SRK2, T and Hoffer Q, the fourth generation, Hagues, and the fifth generation, Holiday 2. But of them, we use SRK2, Holiday 1, SRK-T, and Hoffer Q commonly in children. The first one, the SRK2, combines a modification for extreme axial length. There is a small correction factors for different axial length incorporated in SRK2. The anterior chamber depth is not used, so the correction factor for the anterior chamber depth is eliminated. And several studies have found that SRK2 is most predictable in children. Now, SRK-T combines regression, theoretical with regression techniques, and it includes a retinal thickness correction factor. And it is valid empirically, but it performs better in longer eyes in that of adults. The Holiday 1 has two variables, axial length and keratometry, and the Holiday 1 formula has been found in various studies to undercorrect in pediatric eyes. The Holiday 2 has very many variables which may or may not be possible in very small children to obtain, but it is most accurate in axial lengths between 22 and 26 millimeters in adults. Hoffer Q is accurate in shorter axial length. And in one of the studies in pediatric cataract, it was found to have the least prediction error in pediatric eyes. There is a pediatric IOL calculator which was based on SRK2 formulae with holiday algorithm, and it incorporates small details like refraction, the target refraction now, the goal refraction at age 2 to be fed in by you, and it calculates the intraocular lens power which you need to use if you need a target refraction of this much at this age. I will be discussing 4 important studies which was conducted in pediatric eyes regarding the accuracy of IOL power calculation formulae in children. The first one was by Neely in 2005, published in JPOS. It was a retrospective analysis, a 5-year study period of 101 sample size. The mean age at time of surgery was around 5.7 years, and it compared the 4 commonly used IOL calculations. And the prediction error was defined as the predicted postoperative refraction minus the actual postoperative refraction. And if we take the absolute prediction error, we just eliminate the minus or the plus sign. And this study found that the SRK2 was the least variable amongst the four IOL power calculation formulas that was used, and Hofer-Q was the most variable. The second study came out in 2007 in ophthalmology. It was an analytical mathematical prediction of the IOL implant, IOL power over a range of keratometry and axial length. The keratometry ranged from all sorts, from 40 to 55, and axial length ranged from 16 to 28. And a spreadsheet was generated for all possible combinations of axial length and keratometry values. And they found significant difference in the lens power prediction in Hofer-Q, Holiday 1, and SRK2. So there was significant difference in lens power in this study also when they did theoretical variation of axial length and keratometry. The third study was in 2010 by Nihalani et al. In ophthalmology, and they studied about 135 eyes over a period of 10 years, and the mean age at the time of surgery was 6.2. And they found that the mean absolute prediction error was minimal in Hofer-Q. So this is completely opposite to that of the previous study. But significantly, they found that prediction error was higher in age less than 2 years, in shorter axial length and steeper corneas, that is in short, very small children, less than 2 years, less than 1 year, less than 6 months, like Dr. Coker mentioned. But this was the only study which showed that Hofer-Q gave minimal prediction error, and Hofer-Q was found to be less likely to undercorrect in cases in pediatric eyes. Coming to the last study, which came from India, the L.V. Prasad group, Kekunia et al. In American Journal of Ophthalmology. This was significant because they studied less than 2 years old. So this is what we wanted. The very small eyes were a little unpredictable. And this was a 5-year period study of 128 eyes of less than 2-year-old. And the mean age at the time of surgery was 11.7 months. And they found that the mean absolute prediction error in SRK2 was minimal, and this was statistically significant. And they also found that the prediction error was affected by keratometric values in other formulae, but it was minimal in SRK2. So we have now 4 different studies giving a little different results. So we studied our patients to determine the predictability of different IOL power calculation formulae in our institution. We studied 68 eyes over a period of 2 years. It was done in 2013, and the mean age at the time of surgery was 6.3 years. The mean axial length was 22.4 millimeters. Mean K value was 45.3 diopters. And we found that the mean absolute prediction error was similar in SRK2 and T. It was minimum in T, but it was very similar. 2 and T were similar. And it was higher in Hofer-Q. And we found that there was significant difference between the mean absolute prediction error obtained in all the 4 formulas. So none of the formulas kind of was together in the prediction error. And when we saw the predictability within 0.5 diopters, depending on age, we found that SRKT gave the best results, followed by SRK2. They were close to each other in children more than 3 years. Why we took 3 years? Because our numbers less than 2 years were very, very less, so we could not do a statistical analysis. So we took less and more than 3 years, and we found that in more than 3 years, SRK-T and 2 both did well, and in less than 3 years, SRK-2 did well. And when it comes to axial length, again, SRK-T and 2 were far superior to Hoffer-Q and Holiday. And on the K value, again, SRK-T and 2 performed better than Hoffer-Q and Holiday. So we found that SRK-T gave the least minimal absolute prediction error, and it was very similar to SRK-2. And predictability within 0.5 diopters of target refraction was maximum for SRK-T. And there was a significant difference between the absolute prediction error in all the 4 formulae. So what do we have now? We have different studies. 2005 JPO study showing SRK2 as the most predictable. 2010 ophthalmology study showing Hoffer-Q most predictable. 2012 our LV Prasad study showing SRK2 as the most predictable. And 2013 RS in Kolkata study showing SRK2 and T were the most predictable. So our preferred practice pattern is SRK2 for pediatric patients. Thank you.